Hello, welcome, and thank you for joining this second edition of the Cities Changing Diabetes Rounds, the CCD Rounds. My name is Niels Lund. I'm the global lead for Cities Changing Diabetes, and I'm also the head of prevention and health promotion here at Novo Nordisk. Cities Changing Diabetes works to address urban diabetes around the world, and particularly with a focus on the most vulnerable people in cities. The partnership has grown since 2014 when it was established and now counts more than 35 cities around the world. This means that there are many good and many varied examples of what works around the world, and these CCD rounds is an opportunity to tell some of those stories and bring the people who work with the specific challenges right to your screen wherever you are around the world. So as I said, this is the second one that we are running, and I'm pleased to introduce to you a long-term community intervention that I think everyone can learn from. I'm delighted to introduce Stuart Nelson, Vice President at the Institute for Spirituality and Health in Houston. Stuart will introduce us to the Faith and Diabetes Initiative, which I know has inspired many people around the world. So Stuart will talk 25 minutes and then we'll open up for a Q&A session. And it will work like this, that you can submit questions by clicking the question mark on the right side of your screen. Submit your question also while Stuart speaks, but also after. And I will field the questions to him and then we'll have a conversation going. So not really complicated, but we're looking forward to engaging in this discussion and hopefully a good learning experience here. But without further ado, I'd like to hand it over to Stuart to tell the story about the Faith and Diabetes Initiative in Houston.
Well, thank you so much, Niels, and good morning from Houston. Good afternoon elsewhere in the world, and thank you to all of those who are tuning in. I'm really excited to be here. As Niels said, my name is Stuart Nelson, and I've been working for the last several years on something called the Faith and Diabetes Initiative. So my plan today is to give everyone an overview of the initiative, some of the core guiding principles, and a few examples of how the work has unfolded. Right at the beginning, I'd just like to acknowledge that I'm mainly a messenger today, because the team that has worked on Faith and Diabetes has been robust. It's been so many people have contributed to this work. Novo Nordisk and Cities Changing Diabetes itself making the work possible with the vision for bending the curve worldwide by focusing on urban diabetes. TMF Health Quality Institute, Harris County Public Health, Houston Health Department, the UT School of Public Health with support from Robert Wood Johnson, and in particular, all of the participating houses of faith that have made the Faith and Diabetes Initiative possible. Really, this work is at the very core about those faith communities, some of which are 100 members, others are 25,000 members. And so it's been a really, really great example of collaboration and a team effort. And lots of individuals who are too numerous to name, but in particular, Klaus Madsen and Serena Valentine, and the members of the original Faith and Diabetes team in Houston. So consider me a messenger for this amazing group of people. The Faith and Diabetes Initiative, which was founded in 2016, engages diverse communities of faith to address diabetes through education, prevention, and self-management programs. And the Faith and Diabetes Initiative is currently active in Houston and Philadelphia. I'll be talking about some of the work we're doing in both of those locales today. So the inspiration for Faith and Diabetes came from some early planning that was done in Houston in late 2015. Here you see a chart that I don't expect you to be able to read, but I've highlighted a couple of the cells from this chart, which show that early on in the Houston work, there was a priority around bringing prevention and self-management resources and initiatives and action to faith communities. Priority 2 says that we need toolkits for faith-based organizations. Priority 1 said we need to help people prioritize their personal health over other life demands. And one of the places we can do that, to borrow some language from the Steno Center, a super setting we can do that within is churches and faith communities. And then finally, less specifically, but also related, is we just need to think non-traditionally about how we're going to deliver health information and how we're going to get people mobilized to address this tremendous issue of diabetes in our cities. And so we feel that faith communities are one of those settings. So the question why faith communities often comes up early by people who are hearing about the initiative. And we know from a lot of literature and a growing volume of literature that faith health collaborations are bolstered by the passion that exists behind membership in faith communities, commitment to a tradition, the importance of faith in the individual lives of people living with diabetes, as well as their families and their extended community. And then maybe most importantly, it's bolstered by trust and respect that comes from being a member of a faith community and hearing messaging from within that community. Faith leaders are often incredibly important authorities and sources of information for a wide range of life conditions and experiences and circumstances. And so bringing health information to faith communities wraps it in a kind of a trust and a respect that might not otherwise be present in traditional health systems. Here is some Pew data that you can see in Houston, at least, that 61% of adults, this is from 2015, reported that religion was very important in their life, followed by 22% somewhat important. So there is 83% of individuals living in Houston say religion is either very or somewhat important in their life. And so it really just makes sense. I mean, it's kind of a no-brainer when we think about, where to meet people where they are, and how to meet people where they are. Approaching faith communities and working collaboratively with them just makes a lot of sense. There are some challenges, though, and one of the challenges that we wanted to overcome and really think about critically and creatively in faith and diabetes was this challenge of discomfort, distrust, and lack of a common language when speaking to faith communities and engaging with faith communities from a health standpoint. In the United States, there's a long history of a kind of a fraught relationship between health systems and faith communities, even though we feel that health and faith should be part and parcel of the same conversation and the same lived experience. There is that lack of understanding and lack of common language. So that's something to overcome. And I want to suggest early on in this presentation that one of the key guiding principles that has helped us overcome that challenge is by elevating faith. As we say frequently in the Faith and Diabetes Initiative, we're not just parachuting into faith communities with health information and saying, do this, and this is what you need to practice and do, and these are the steps you need to take. We start when we engage with faith communities by asking, what is important and special to you? What are the traditions that are important? Tell us about your tradition. Tell us about your faith community. Tell us why you believe the way you do, and leverage from there in an effort to build a common language from the health professional standpoint, whether it's public health or clinical health or dietitian or whatever, building a common language around faith and the understanding about how to talk about spirituality and religion. And then on the faith leader or the lay leader's side, building a common language around health. So this is this very collaborative process that really meets stakeholders where they are. And that works the other way too. The faith community really also meets the health community where they are too. So we come from these different points, and through dialogue, we're able to do some pretty amazing things. And then the final guiding principle it's woven through all of the work is this idea that we need to be specific enough to be effective. So do things like base our interventions or our suggestions on empirically based, research-backed interventions, kind of know where we want to go in a general sense so that we don't get lost at sea, so to speak. But then we also have to be generic enough to be adaptable, because the faith communities we deal with and we work with and we're in collaboration with, they have different needs, they have different expectations, they have different ideas about what success looks like. And so this tension, we call it in our work a creative tension between specificity, being specific enough, and then being generic, so that we can bring this program to a whole range of different traditions, different size congregations, different locations, different cities. We have to have an open template that allows for that kind of flexibility. So I'll start by doing a little bit of a dive into the Houston work, which is where Faith and Diabetes Initiative began. It's my hometown. It's where I'm from. It's a wonderful city. It's the fourth largest city in the United States. It's incredibly diverse, and by some measures, it's the most diverse city in the United States. And it's also, according to some research by Stephen Kleinberg out of Rice University and the Kinder Institute, it's a city that the demographics are anticipating the demographic makeup of the rest of the United States by about 20 years. And so what we learn from Houston hopefully can be applied and adapted as we move forward into other work in the United States and beyond. The faith and diabetes ecosystem in Houston, at its very core, is these faith communities. And so I want everyone who's watching and tuning in today to just keep that as an anchor, to keep that as kind of a North Star for this work. If you're considering working with faith communities, it starts with and ends with faith communities. Around that in Houston, we had a project team that was a multi-organizational project team, some organizations with some funded ability and some doing in-kind work and rallying together to really steer the project. The next layer up is an action work group that was larger. It was about 35 or more individuals that came together in order to create the program and envision what this program could be like. And then beyond that, we had a core team in Houston that was involved in coordinating the initiatives, the other initiatives in Houston, peer support programs, and diabetes prevention programs and others. And then finally, the CCD stakeholders. And in many ways, that's you all. That's everyone tuning in today. We all have a stake in even the fine granules of this work, and the conversations that we were able to have at summits and with the global team and from other cities. It all infuses into this work and is inspirational. So this is this ecosystem we're working within in Houston. The Faith and Diabetes Action Work Group, seen pictured here. At the beginning, we met every couple of weeks, every 2 to 3 weeks, in order to really understand what we were trying to accomplish. And it was great. It was a creative, generative, multi-perspective group that really brought a lot of richness to the planning process that looked something like this. And don't be overwhelmed by this slide. I'll kind of walk us through. When we first started the Faith and Diabetes Initiative, we decided to hold a summit in October of 2016. And that summit invited a bunch of different faith communities together, over 120 participants together to share resources and to gain kind of an understanding of the pulse of this work, the existing work and what needed to happen. And our learning from that was that many health ministries, while motivated to do work around chronic disease, self-management, and prevention, weren't really prepared. They didn't have the infrastructure, the time, and so there needed to be some capacity building. And so the Action Work Group set out to design a program, a training curriculum, to meet that need. And we generated a training that in its first iteration was 6 weeks long, that had several modules from diabetes prevention to self-management to sort of diabetes 101 type material, to religious studies module, which I'll talk about in a little bit. And we invited 23 diverse faith communities across different traditions and denominations to nominate lay leaders to participate in that training. And then once the training completed, we had some continued engagement in terms of some reunions and some continuing learning opportunities, and for a period, some support. This is the training schedule that we ultimately landed on in Houston. Won't spend too much time here, but just wanted to show that we initially had 3 training days and then an implementation phase where our trainees went back to their faith communities, implemented a 6-week DSME program, diabetes self-management education program, and then came back to reflect on what they had learned, to bolster their skills more, and then they were out in the world doing the work on a continuing basis. One of the key aspects to the training that I want to focus on, and in some ways this slide is the heart of this presentation, because it is what we did to form that common language around faith and form an understanding of where our participants were coming from. We started our trainings. We continue to begin our trainings in the early phases of trainings with a religious studies module where we do a deep dive into the beliefs and the practices and the elements of community life that define these traditions and these places. We talk about food that's important to these traditions, texts that are important, and scripture. We talk about times and seasons and holidays that are important. We talk about ways of communicating news. We talk about people that are important, all the way up from, tradition leaders, all the way down to pastors and lay leaders. We talk about rituals and practices that are important. And through that process, we build trust, and we get curious, and we have then by the end of that, we have the tools and the kind of the creative parts that we need in order to build innovative programming that will speak to the needs and the language of the communities in which we're working. So we don't come in with preconceived notions about how faith and health link. That's something that we encourage our trainees to come up with themselves. How does this scripture that's really important to my tradition, how does that apply to health? Or what food is really important, and how might we think about that food in a different way when we consider chronic disease management and prevention and obesity? So it's a very creative process, and that's really what I want to encourage anyone who's thinking about doing faith and diabetes type work. Think of it as a creative process where we're really digging into the traditions that we're a part of. In Houston, as I said, we had just over 20 communities of faith participate from across denominations. We had 43 individuals graduate successfully from the training program. And you can see some of the changes that participants that enrolled in the DSME classes realized. We had improved knowledge over the role that exercise plays. We have improved confidence over ability to manage diabetes-related stress, so some of these psychosocial effects of living with diabetes. And then improved knowledge about behavioral change. And an interesting thing to note here is many of our participants noted that while they had learned and participated within the context of a class, they were spreading this knowledge throughout their family unit, throughout their social community. And so we believe, and we found that the impact of enrolling in a class like this extended far beyond the participants that were actually enrolled. It wasn't just a single person change. It impacted the family system and beyond. In Philadelphia, we took a slightly different tact, and it's been just such a pleasure to work in Philadelphia. The team there is great, and it's been a new experience for me personally and some of the others who have been working on faith and diabetes for a longer term. And it's been really a nourishing experience there in Philadelphia. In Philadelphia, we took a longer view. We took kind of a two-pronged approach. I'll talk about the second in a moment. But the first prong was this action work group model again. But instead of getting the action work group to create one single curriculum for faith communities in Philadelphia, we invited different faith communities to actually make up and be a part of the action work group. And we led them through a 16-session program, which was kind of a hybrid of information sharing, diabetes self-management training, religious studies kind of generativity and creativity. And the ultimate goal is for all of our participants there to create their own programs for their particular house of faith that resonates with their beliefs and practices, as well as what they learned through the way. And I'm really excited to note that this week actually is final presentation week. And so I'll be really excited next Tuesday evening to hear the presentations from our participants and hopefully implementation within the next couple of months. The other component to the Faith and Diabetes Initiative in Philadelphia, which has been great, led by Damon Davis and Maurice Madden, has been the Philadelphia Innovation Collaborative. And so this prong of the Faith and Diabetes Initiative involves 5 faith communities that had submitted ideas to the Philadelphia Innovation Challenge and weren't selected, but were able to continue meeting in order to flesh out these ideas and envision programs and also a common framework called health cabinets that faith communities and ministries can use to organize going forward. And so again, there's these currents of thinking carefully about how faith communities are already doing work, what's important to them, and then how we can build on that success. This chart summarizes the projects that are emerging from the last 8 months of work in Philadelphia. And you can see that the projects cover the gamut of topics from self-management education to awareness raising, peer support under the leadership of Serena Valentine has just been such an important part of these programs, food-focused interventions and programming, and then in some cases youth-focused programming. And you can see the diversity of faith communities involved on the left-hand column. We have AME Church represented, Baptist churches, synagogues. In Houston we had, and in Philadelphia too, we have Muslim participants. So it's really a rich a cross-section of the Philadelphia community. So I want to just wrap up in a couple of minutes by saying that there are some key takeaways that we've learned and that I hope to impart onto everybody who's tuned in today. And of course, Niels and I will have more of a conversation about some of these things when we talk. But just 3 takeaways that are just especially important, and that if there's anything you lift from this presentation, I'd like you to take away. The first is that it's very important to involve all levels of the community from the beginning of the work. Our initial action work group in Houston, as well as the early town hall meetings in Philadelphia, involved all levels of the community, from people living with diabetes to lay leaders in faith communities to youth voices, to officials from the city, to folks from Cities Changing Diabetes leadership, from health organizations like the Healthcare Improvement Foundation in Philadelphia. So it's a really a diverse set of partners that are engaged right from the beginning, and from there the creativity wells. It's also important to pay attention to what's important to those who you're trying to reach. Again, this theme has been massaged through this whole presentation of really listening and paying attention to what matters to the people on the ground who are ultimately probably going to be doing the groundwork. They're going to be the boots on the ground. So they need to be engaged by having a stake. And their stake is kind of identified by paying attention to what's important. And then finally, it's important, and this is a challenge sometimes because a lot of people who are really excited about this work think so big. But capacity is a really important consideration. As I've mentioned, some of the faith communities who are involved in this work have 100 members total, and so it's important to recognize that in order to affect the changes that I think we want to see within Cities Changing Diabetes, and certainly the Faith and Diabetes Initiative, we need to create room for those players to be not just present, but have a voice at the table. Because I've been very surprised at the impact that even small players can make in the ultimate landscape of the Faith and Diabetes Initiative. So it's a really important one to think about. Everyone is welcome at the table, and should be valued. Our vision for faith and diabetes moving forward is global. We want hundreds of faith communities in dozens of cities around the world to know about faith and diabetes and to do the work and to create their own faith and diabetes initiatives. I know this work would be valuable in many of the 35 cities that are part of Cities Changing Diabetes, and we look forward to seeing this unfold well into the future. This process is iterative and it's cyclical, and so we really want to come to the work with a beginner's mind each time we engage, in order to not make assumptions and to learn from the work and refine and tweak and adapt moving forward. This work, as hopefully you've gathered, is not static. It's dynamic work. It's creative work. There's an art to it. And so we really want to be responsive in that kind of a way. And then we want to share. We want you who are watching to share your experiences working with faith communities. We want to be able to share with you our learnings and insights. And we want to be able to walk forward kind of unified in this faith and diabetes initiative and movement, learning from each other. That's where growth happens, and that's where impact occurs. There are several ways you can engage with the Faith and Diabetes Initiative, and I encourage you to do so. We have a case study that's accessible on the Cities Changing Diabetes website. There's a blueprint, which is sort of a companion document to the case study that's going to be available in early June. And that's really kind of a manual or a how-to guide to implement your own Faith and Diabetes Initiative wherever you are. And by the way, that's whether you're in a Cities Changing Diabetes city or not. You can adapt this work any place you choose, but we do want to hear from you if you do this work. The release of that document will coincide with a workshop that's also will be scheduled for early June this year. And so we invite anybody who's sort of taken by that idea or has some curiosity around it to join us there. And then you can always reach out to info@faithanddiabetes.org, and we'll look forward to receiving your ideas and insights and aspirations moving forward. So that concludes my presentation. And Niels, I'm really looking forward to boring down into some of the nitty-gritty with you right now.
Thanks, Stuart. Really exciting and really inspiring also. I think you've demonstrated how you're both trying to be specific yet generic, and I think the fact that you could move from Houston to Philadelphia and also inspire other cities that I know of in as part of our network, is testament for that. I think it's also good that you put this into a manual or the blueprint that you're working with, and we'll make sure to share both the date of the event, the workshop, but also the material both on our site and so on, so others can use it. There's so many things to dig into. Let me start from the beginning, because I think I visited Houston the first time in connection with the Cities Change Diabetes program back in 2014, and we started doing research. And one of the findings was that many of the people who were at higher risk of diabetes were affected by isolation, social isolation, and also had a degree of mistrust in the formal healthcare system. And when we talk about these things, houses of faith appears to be a solution to that. But can you elaborate a little bit more about that? I think you touched upon it in the beginning, but how do you build that trust bridge between people who basically do not trust others and are also isolated?
Certainly, Niels, it's a great question. In the U.S. context, I think it's really important to just name that there's been maltreatment within minority communities from the health system. There's been a whole history and legacy of fraudness and a real difficulty. So encouraging people, especially who have been sort of burned in the past, to engage a health system is not easy. I mean, we're seeing some of that play out right now with vaccine rollout with COVID. And so people who have common experiences, a common history, a common generational history, we're not just talking about one life, we're talking about generations of experiences that build and swell into faith traditions and movements. When you feel a part of that family, there's an implicit level of comfort and trust because you've been through the same thing I've been through. And so that's family, that's home. And so when people at home start talking about things, suddenly the ears perk up a little bit more than some outsider saying, well, I know we burned you in the past, but now we really have good intentions and we really want to come and we really want to help. And so so that becoming present with the process of becoming really present with these histories is really important. I'll also just say very simply that sometimes health isn't so fun. Sometimes it's kind of a cold process. Going to a hospital isn't something that I get really excited about. Going to a community that matters to me, though, and being in fellowship with my friends and my family and those who I love, it is fun and it is exciting and it nourishes my soul and my spirit. And so, I mean, on that level as well, we really we can really wrap some of it in those traditions. I'll say one quick anecdote, which I think helps illustrate this point that I was struck with. In the second cohort in Houston, we had a pastor from a Catholic church that was largely Hispanic, and he, in the kind of creativity process, he noted that there was a big tradition in his faith community of folk music, Mexican folk music. And it wasn't necessarily religious music, but it was these folk songs and tunes that really were popular in the community. And so when he thought about how to deliver his diabetes self-management course, he said, well, what we're going to do is we're going to have these little mini concerts before and after each session. And we're going to play these folk songs that make people feel safe. They make them feel happy and jovial. The music, is really a powerful medium. And so we'll bookend the learnings with our folk music. Mm. And I just thought that was brilliant because it doesn't need to change the curriculum at all. It's just a little bit of time on either end that wraps it in that warmth. It makes a potentially cold, kind of boring thing into something full of life and full of richness. Oh. And so I would trust that more. Oh. I would feel better. There. And so that's what we're finding. Yeah.
It's interesting. I think the whole concept of community is one that we see, working well across the cities that are part of the Cities Change Diabetes Network. Close to home in Copenhagen, where I am right now, it's without the side outside the faith community, but in the early research, we would ask middle-aged men, probably my age, with significant risk factors for diabetes, saying these local community health centers, they're not a place for me. I mean, I would never think about going there. It's not for me. So there you should try to maybe go through where they are. In the housing communities or in their local neighborhoods, and then reached out to them. And I think it's the same type of thinking when it comes to your the work that you're doing. Would like to have others participate in the conversation also, and I can see some questions coming in already. If you have. I'll just say it again, click on the question mark to the right of your screen and then post the question, and it will be fed to me, and then I will do my best to read them and give them to Stuart, and we can hopefully get a conversation going. But I have one more. I mean, I have several, but one thing I caught in your slides at a certain point that, you were focusing on lay leaders, not faith leaders, in terms of who actually going to be operational in delivering the health messages and so on. Can you explain a little bit more about why that is and why that has worked, and why you wouldn't do it with faith leaders in the program?
Certainly, Niels. It's a great question. So it's kind of a multi-pronged answer. I'll just begin by saying that faith leaders definitely aren't excluded from the work, and if they do have the capacity to engage, then we welcome them, and that's really great. Although that touches upon sort of the first answer to the question, which is that in many cases there's an issue of time and capacity. Faith leaders are incredibly busy, and they have their job, which is to be the spiritual leaders of a community and work with the community on a whole range of issues. And so they're spread thin. And so we want to inform and involve and make sure that faith leaders are communicated with and we have their blessing, so to speak. But we find that lay leaders have a tremendous amount of passion and motivation for doing this work, and a real quality of leadership that in some cases is untapped. I can't tell you the number of times we've in a leader in the initiative that said, "Well, I never thought that I could do this work. I never thought that I could be a leader. But now I'm starting the very first health ministry that my faith community has ever had." And so when people have those experiences of success, and when they have those experiences of impact, it's just a catalyst for even more. And oftentimes too, like in even in a health system, sometimes those folks who are not physicians have a really good understanding of what's going on the ground in the faith community. They have a different kind of a perspective of need and what the community can be rallying towards. So for some of those reasons, practical but also creative, we really love working with lay leaders.
Really interesting. So there are a couple of questions have come in here. Actually, some of them discussing or asking, in the context of COVID-19 and the pandemic, how has that affected you? Let me just read the question here from Sophie. Having witnessed this wonderful group training in Houston a couple of years ago, it would be interesting to hear how COVID impacted the running of the program, both the training, but also how your faith and diabetes leaders are supporting their peers in a more virtual world.
Yeah, thanks for that question. Well, I mean, at the very basic level, the training in Philadelphia was supposed to be in person. And we had planned on in-person training until, I guess March of last year. And so we pivoted to virtual, and we adapted that way. It's worked quite well. I think because of access. I mean, the virtual environment definitely has its pitfalls, and people can get tired of looking into a screen, but it makes it easy to kind of like maybe get off work and then immediately be in a training, or be at home and dealing with family life. So when we're working with lay leaders, I've seen some of that barrier to entry be reduced, which is good. We've also seen an impact in the sense that COVID for many of these communities is what's happening right now. And so sometimes chronic disease prevention can be, because it's so omnipresent, it can be de-emphasized because right now we're dealing with a pandemic and we need to respond to that pandemic. But we've seen intersections which are really interesting between the diabetes and obesity work and the COVID work, which is isolation, fear, skepticism. Those are all parts of both experiences, and some of the mental health considerations that are a part of living with diabetes as well as being in a pandemic environment. Those are the same. And so I think there's been a tremendous value in a time of isolation to be able to be together and to talk about health, because many of the systems that are being put in place and being grown within our faith community participants will be useful not only for diabetes and obesity work, but they'll be useful for all kinds of health work. As I said, some of our participants are creating health ministries for the first time, or doing substantive programming for the first time. And so that template can extend to to a pandemic. It can extend to heart disease, can extend in a lot of different directions. So those are some answers. I feel incomplete answer, but hopefully that's helpful.
I think it's when we look at COVID and then diabetes and obesity and put them into a cocktail glass, it becomes a really bad cocktail, because the risk exacerbate and or multiply in the sense that it's not to have either, but it's really bad to have all three at the same time. And I think we cannot rely just on the formal health system to address this, particularly when we look at prevention. And what you're doing is certainly prevention or self-management in that regard. When you're outside the health system, that's where you need to address all of those multitude of factors here in a way and see how you can prevent the disease. There's a question from the guy who actually sat in your chair last time, Paul from Steno. He says, and I'm looking at another screen, that's why I'm veering a little bit off. Training and capacity building is one thing. Absorbing what has been learned and integrating into everyday life is another. Especially for vulnerable people who struggle with so many challenges, and that's probably also the case in Houston. What mechanisms and support structures for fostering sustained behavioral change have followed after the training? So, what happens next, basically, for the ones who have been part of this program?
Yeah, that's a great question. Thank you so much, Paul. So that it's not. I mean, frankly, it's not always easy, as you intimate. That said, we have Houston and Philadelphia have offered differently, have operated differently. So I'll talk about Houston first. In Houston, well, actually, let me back up. In both cases, part of the goal has been to encourage the faith communities to build systems of support from within, to where they rely on outside help less and less over time. And so we hope that by speaking the language of the faith community throughout the capacity building process, that begins to weave itself into a culture of health that sustains within the organization. That may simply be a policy change within the community in terms of prevention. It may be identifying and ensuring that there's an advocate for the work within the community who is a longtime member of the community and who will continue to be a longtime member of the community. In Houston, once the training concluded, we had about a year and a half or so of sustained programming, reunions. We had people come back to receive presentations from organizations that are involved in the work and have kind of parallels to the work. We had a full-time staff member who at the Institute who carried the work forward and tracked outcomes. And so, and really was there to call or to answer the phone if anybody was struggling. I mean, simple things. I mean, sometimes people just needed a place to meet. They said, our faith community, all the rooms are booked today. Can we come up to the Institute in order to meet with our team? And so we were available for that. So in the same way that when you create a new friendship, you don't just kind of ghost or leave a friend hanging. We're always there for our faith and diabetes cohort to call and continue receiving support. Some of the direct sort of instigated by the team support has waned over time, but we're always available to collaborate and innovate with those individuals. I mean, a great example of that is Serena Valentine, one of our most engaged trainees, who's now a leader within the Faith and Diabetes Initiative. She operates Houston Peer Support, and for a number of months and a couple of years before COVID, was running peer support trainings at the Institute, and also using a couple of ISH pre-existing ISH partnerships to roll out DSME classes. And so trying to just continue maintaining those relationships. In Philadelphia, it's yet to be seen. right now we're at a phase in the work where the Healthcare Improvement Foundation, a wonderful local nonprofit in Philadelphia, is going to be shepherding and stewarding the work going forward. And so we'll see how engagement continues. We're just coming off of this 8-month training program. And so some of that future engagement has yet to be seen. But thanks for the question, Paul.
And I think sustainability of the initiatives is something that we all think about and hope that we can in some way or another address. So I know that you have worked specifically, with specific houses of faith or traditions. So, one here, one here, one here. But I also know that you have experience of bringing faith communities together and different traditions and have conversations across. And there's a question from Wendy that actually is related to this. Were there any conflicts because of different faith cultures seeking different pathways for how to move forward, and how were these conflicts resolved? Or maybe you can also put it in another way, were there things that were mutually supportive and where you could leverage the different faith communities and the different traditions? And so what was the nature of those discussions, and what have you learned there?
It's a great question. Thank you, Wendy. There's always some trepidation when we bring different people together. We all have the experience of being in an environment that is new, or being around people that we might not normally hang out with, different even professionals that we might normally encounter. So that feeling of vulnerability, particularly when you're talking about some of the most important beliefs and practices to you, is real. What we found, though, is that the way in which we've conducted the work has allowed for these really amazing touch points between faith communities, and recognition of similarity and shared humanity and shared beliefs, and shared experiences with the body and health. So I remember in the training that, like, the second session in Houston, there was one of our participants said, I really didn't realize that diabetes was a problem outside of the Black community. And it was an inflection point for the work, for her and for us, because we realized that by bringing people together, we were shining light on the fact that this is a shared issue. Now, from a tradition standpoint, we also saw some pretty amazing touch points. So we began most of our sessions with a moment of a prayer or reflection or silence. And so sometimes, a Muslim participant would read a prayer to start us off. Other times it would be a Baptist participant, Methodist participant. And in reading the texts, in reading the scriptures, in doing that deep dive into the religious traditions, there were some really interesting connections made between, and statements like, wow, I didn't really realize that the God that you pray to 5 times a day is the same God that I pray to when I'm at church on Sundays, or when I'm around the dinner table. And so it really was an implicit thing. It wasn't a stated goal at the beginning of the Faith and Diabetes Initiative to do interfaith dialogue. But through the process, that was a really beautiful and maybe one of the most important things that we've been able to accomplish, is bridging gaps and breaking down walls between communities that otherwise would be siloed and not collaborating together. The Spanish-speaking community in Houston, the English-speaking community in Houston, African-American and Latinx communities, various denominations within Christianity, Eastern traditions and Western traditions, all around the same table. And conflict is always a fear, and it needs to be carefully kind of thought about. But if done in a way if facilitated in a way that's defined by mutual respect and understanding, I think the possibilities are great for togetherness rather than separation.
Yeah. So I'm not a religious expert by any standard or any faith expert in that regard. So please allow me maybe what you could consider an ignorant question or an observation, because and I think it relates to a question that also comes from Arthur in the box, that on the one hand you can have faith communities where science and faith is well integrated, and it's that there are things that in terms of how you eat, how you exercise, how you live, you understand also from a scientific point of view how that impacts your risk of diabetes. And then you have other faith communities, and that's an observation we had from Mexico City, that you see that the fact that you develop the type or have a risk factor for diabetes, it could be obesity or develop diabetes in itself, is an act of God. And so it is a more what I would consider a more fatalistic, faith-based understanding of how you deal with or understand the risk of diabetes. And these two are not the same, and might actually collide in a way. And then I can as the pragmatic science-based person that I am, I can understand how you deal with the first one, but more struggle with how do you work with the second one. Is that something you have come across, or as an expert in this field and the different faiths, how would you approach that? I understand, there's not a one size fits all, but how would you go about this, or have you seen it?
Yeah, a couple things come to mind, and it's a really great question. And when we really start wading into the waters of theology and different ideas of the way that someone's belief in God might impact our behavior here in life, it starts getting really interesting and really complicated. But a couple of basic thoughts. The first is that, by and large, the people who we engage in our trainings and through the work are individuals who are motivated to make healthy changes in their communities of faith. And so they play this dual role as people who are bought in to the health aspect and the health side of things, but they also play a role as somebody who's intimately familiar with the beliefs and practices of the community that they're working within. So that's why it's especially important not to just drop in and try to convince people to do stuff. It's involving them from the very beginning to say, how can this work unfold? I teach some contemplative practices, and one of our contemplative practices is a movement practice where we dance. And when I lead that practice, I always say, if you can get up and dance, great. If you can sit in your chair and just move your arms, great. If you can just not even move your arms, but just move one finger and dance with one finger, great. Meeting people where they are is incredibly important. And so if there's an aspect of the work that they feel that their theology prohibits them from doing, if there's that barrier there, then it's time to get extra creative, and there's always a path forward if we're creative enough. There is, and get curious. Maybe you don't want to do this behavior change or go to this series of classes, but it must not feel good to have this symptom or this side effect or this complication. If we could alleviate that, does that sound like something that might be within God's plan for your life? Okay, it does. So it's this process of inquiry, process of creativity, process of presence, rather than kind of forcing a solution.
And I think what I really like to underline is also what you said at the beginning. It starts with faith, and then you move on to health. I mean, understanding, appreciating, working with the faith and the traditions and the theology, and understanding how that affects people more than I will probably start with the health stuff because that's so close to me. But I really understand how this actually might be the door opener for a deeper conversation about how you then can talk about health in a faith context.
That's right, Niels. And I just want to return to one point because I don't know when and if I'll be able to get to it. But you mentioned the men that say this place isn't for me, right? When they're talking about the clinic, And one of the things that threads through the Faith in Diabetes initiative is, and this is a good take home for everyone, is that this work doesn't have to be just confined to religious institutions and bodies. It really is about specialness and what's special in the lives of people. So when dealing with one of those men who you were describing and working with them, they may not be part of a religious tradition, but they may have a hobby, or they may have a club that they're part of, or they may have a belief about the way the world works that they talk about with other people in their social setting. And so tapping into what's special and important in the life of that person, and then leveraging that creatively, whether it's maybe a dominoes club or a poker, club, or a bowling, is a hobby of theirs. Finding those access points into the lives of people who we want to affect healthy lifestyle and inspire to do healthy lifestyle change is really effective. So it's not only religious, although in this context we've been talking a lot about religious traditions.
No, but what you're also addressing is the importance of working through peers or with peers in this regard. That it is. That this is the way that you build the bridge between two people. If there's an area of commonality, it could be faith, but it could also be, basically also that you either bowl or you maybe you go to the local bar every other night, and then you meet them there. There are different places where you can meet to congregate without belittling the initiative that you have been doing.
Right.
I will. I think we'll need to go to the final question here about you talked about capacity building, and you also build capacity. So you built a learning. This is from Mette. You have built a learning community that can support one another over time. What's the role of the community health workers here?
Well, community health workers, for those communities that have them and that have access to that role, it's really, it's tremendous. Whenever you have community health workers who are involved in the work, these are sources of expertise, oftentimes trusted members of the community, oftentimes people who have been doing work for a long time. And so this is another layer of the work, is not being so kind of like pretentious that where we have this new thing that is like radically innovative and everything. It's paying attention to what infrastructure is already present, and community health workers in Houston play a large role in the health system as trusted supporters of health and promoters of health, and so involving any professional at that level in the work is important. And also, it leads to another kind of aspect of the work, which we don't have time to talk about. But anytime a professional organization or an existing infrastructure can be incorporated and plugged into this work, that's really great. It's a tremendous benefit. It gives you a head start. And so if there's a great community health worker infrastructure within a city, or an analog, if you're, don't use that term, plugging them in from the beginning, remember, engaging the community from the very beginning, it'll accelerate the work and catalyze success.
Super. I'm sorry. That's what I think we could have kept going for longer, but this is the time that we have, and we want to end on time. So many thanks, Stuart, for sharing the valuable insights. It's really been a pleasure. And to the rest of you viewing here, we hope you can use these insights, and also that it can inspire you for your work. If you missed a point or two, then you can. Then the recording will be available on YouTube. You go on YouTube and search for Cities Changing Diabetes, and the link will be up quite soon, probably either later today or tomorrow. Also, as mentioned by Stuart, there are several ways to get further support if the initiative would be relevant in your local setting. As mentioned, there will be a blueprint available and a workshop available in June. And for the ones who are part of the Cities Change Diabetes newsletter, we'll be sharing dates for that. And we'll probably also find a way to share those data on social media. So follow our channel here at Cities Diabetes. There's also an extensive description of the faith and diabetes best practice on the citieschangediabetes.com website under Action Framework. And if you have unanswered questions and would like to learn more, send us a message either at info@citieschangingdiabetes.com or info@faithanddiabetes.org. And that is probably what you, Ingrid, who also asked the question about whether you could get the slides. You could send us a message there, and we can negotiate the terms of that with Stuart here. The next CCD round will take place on the 18th of June, where we will hear about the work of Healthy Goals in Leicester from Susie O'Connell and Alison Tripney. And I believe it will be just as exciting as it was today. But once again, Stuart, thank you very much for your presentation, and thank you to everyone who joined today. Have a wonderful day, whether it's short or long. Thank you.